Hey there, and welcome back for Lecture 4. I'm Dr. Varela. Today we'll be going over the armamentarium that you'll be using to administer local anesthetic to patients. So let's get started. The first piece of equipment that we'll go over is actually the syringe. Now, believe it or not, the American Dental Association actually has criteria that syringe manufacturers need to meet, to have ADA approval. Now, as you can see on the screen, the local anesthetic syringe must be durable and be able to withstand repeated sterilizations without being damaged. The biggest thing that I've seen is that sometimes cheaper syringes tend to rust in areas specifically where they have texturing for maximization of grip, which really isn't only just gross, but it may also be somewhat problematic if the rust happens to contaminate the local anesthetic carpule. Syringes also need to be able to accept cartridges and needles from different manufacturers. Now, once you get out into practice, you'll realize that carpules and needles from different manufacturers are slightly different in appearance, but they all should be able to fit properly and predictably on a standard syringe. Now, from my point of view, this is kind of a matter of safety as the ADA is concerned, because if you happen to have a rogue manufacturer that is producing and selling syringes on the internet that claim to be compatible and actually are not, you could end up in a lot of sticky situations as a dentist. For example, if you're working on a patient and the needle happens to come loose from the syringe while it's in the patient's mouth. Syringes should also be affordable, self-contained, which really kind of means that it doesn't really require the user to assemble several pieces to make it work. And in essence, the syringe should be one or two pieces total. It also needs to be lightweight and simple to use with one hand. You'll notice that most dental instruments, including the syringe, are designed to be pretty lightweight so you don't get that muscle fatigue and strain from heavier instruments. Finally, syringes need to let the user aspirate effectively as well as be able to see the aspirate. And I'll go over this point in a little bit more detail later on in the lecture. Now, there are a few different styles of syringes available to use in dentistry. We really only use one style here at the UUSOD, and it's a pretty standard style, but I want to show you everything that's out there. Really quickly, before we go through that, let's go through the anatomy of a syringe. First, you have the needle adapter, then you have the barrel here, the syringe barrel, and then you have the breech, which is on this side, and you have a window that's on the other side that's slightly smaller opening than the breech. You have the finger grip, then you have the thumb ring that's connected to this piston, and at the end of the piston there's a harpoon, and that's what actually impales the rubber stopper inside of an anesthetic carpule to basically push or pull, creating differences in pressure inside the carpule. Now, the style that we use, you'll see that there's a lot of different styles here. The style we use is a breech loading metallic cartridge type aspirating, which means the following. Breech loading means that the anesthetic carpule is loaded from the breech or rear of the syringe. Now, in reality, the breech on a syringe is really kind of on the side. The side breech gives you that visibility to be able to see the glass carpule, and you can also see it from the window on the other side of the syringe barrel. Metallic refers to the material that the syringe is made out of. You can have metallic or composite plastic fiberglass syringes, which I don't particularly care for, but you can have different types of materials that the syringes are made out of. Cartridge type refers to the style of anesthetic container being loaded into the syringe, and we use cartridge or carpule glass style of containers. And finally, aspirating means that you, as the user, will have to manipulate the syringe in order to aspirate fluid. Now, this style of syringe is really pretty standard, and you'll find it everywhere in the United States. But we do have a few other styles. The next style is known as a breech loading metallic cartridge type self-aspirating. Now, really, the only difference between this type and the standard style is that it has an aspirating function built into it. Now, instead of you as the user pulling back on the thumb ring to aspirate fluid, um, the aspirating function is really kind of built in. Now, there are actually a lot of different mechanisms that help this to work. Some of them will aspirate by placing pressure on the plunger. Some of them will do it by placing pressure on the diaphragm, and then others will actually use an elastic to pull the piston back instead of you having to remember to do it each time. But all of these designs are really aimed to do the same thing. They're aimed to provide an automatic mechanism for aspiration of fluid to occur so that you as a user don't have to remember to do it every single time. Now, I've included some links on the slide to some videos that show a few different styles of self-aspirating syringes, just in case you were curious. Now, those videos are really just kind of for your enjoyment so that you can uh, edify yourself, but they not really will be on a quiz or a test. Really, what I would want you to know for a quiz or a test is what is the difference between a breech loading metallic cartridge type aspirating and a breech loading metallic cartridge type self-aspirating syringe. The next style of syringe is known as a pressure type syringe, and these have some form of ratcheting function, a lot like what you would find in a caulk gun that allows you to apply more pressure on the carpule. Now, typically with this style of high pressure syringe, you're really only able to use extra short needles because longer needles can cause the pressure inside the carpule to increase to such an extent that the glass starts to break. Which can happen, and it's happened several times to me over my career, even with extra short needles. Now, this type of syringe is actually pretty common as well, and it's typically used in endo or perio or even oral surgery types of situations. It's used in situations where you might need to apply a little more pressure to deliver the local anesthetic into tight spaces, such as the PDL space, and a little bit more pressure than what your thumb might be able to accomplish. You probably want to have a couple of these around, or maybe more, if you plan on doing a lot of endo, perio, or oral surgery. And you'll probably hear these being referred to as a LigaJet or a LigaMaJet. And I've included a link to a video that really kind of shows you how to assemble it, because I think it's important for you to know that this is a pretty common thing to have around the office for those types of situations that I described. One thing I don't like about the video that I linked is the way that the user removes the cap from the needle in the video. And I'll actually teach you the way you'll be expected to uncap the needle properly in my own video that will be posted in this week's module. The last style of syringe is known as a needleless syringe, and this type of syringe really kind of relies on high pressure to deliver the anesthetic fluid into the tissues. Now, those of you who might like the show Star Trek might be familiar with this, with the hypospray, and the hypospray on the Star Trek, for those who don't know what Star Trek is or haven't really watched it, is really kind of a delivering system that uses high pressured air to deliver a fluid without a needle transdermally. So they do have certain types of needleless syringes that allow you to do that. One that's used pretty frequently in pediatric applications is called the Magic Wand, and it has a lot of benefits. First, it doesn't look like a needle at all. You can see here that it really just kind of looks like a wand, and it has a lot of capabilities to give you control over the speed and quantity of local anesthetic that's delivered. And it's great for situations where you have patients that have high dental anxiety or who are a little bit less able to comply due to their dental fears. Like children, this is really great for patients with high dental anxiety. This is also really great for patients with special needs because it really kind of puts them at ease. They're not seeing your typical standard syringe and needle assembly, which can be a little intimidating. These kinds of systems are actually pretty common because they give the user a lot of control over the experience. Moving on from the syringe is the needle. Now you'll see the anatomy of a typical dental needle on the screen. Now here we start on the left with the bevel. And the bevel is really kind of designed to assist you in efficiently penetrating the soft tissue without causing any unneeded trauma. Below the bevel we have the main body or shaft of the needle. Now the shaft is connected to this big assembly at the hub, and in this picture the hub is made out of metal. In other needle type in other needles that are produced by different manufacturers, it can actually be plastic, and that really the hub connects the needle to the main syringe adapter. And then on the other end we have the cartridge penetrating end. Now the hub is really kind of the most critical structure to be aware of because this is where the majority of needle failures and breaks take place. And so we'll be coming back to this in just a moment. Now the cartridge penetrating end is really kind of the only part of the needle that makes contact with the inside of the anesthetic carpule, and that's important to know. Needles come in a few different lengths and thicknesses. Ultra short needles are usually only 10 to 15 millimeters long, and as I mentioned a minute ago, they're really just used in applications where a pressure type syringe is needed. They're usually very thin needles, and because of that really should never be bent. These needles in our student clinic are usually capped by a pink safety plastic cap. Short needles are usually between 20 and 25 millimeters in length and are the next size up from the ultra short. Now, short needles are a bit thicker than the ultra short, and they are a little bit longer, 20 to 25 millimeters. Here at the UUSOD, you'll be using the short needle for almost every injection except for the inferior alveolar nerve block, and I'll explain why that is in a moment. These needles in our student clinic are accompanied by a light blue plastic safety cap. Long needles are the longest and the next in the series, and they are the longest and thickest needles that we use, and they're typically between 30 and 35 millimeters in length. Now these needles are really quite thick, and although they make the initial penetration into soft tissue quite a bit easier for you, they can also cause a little bit more pain for the patient. Now you really don't want to use this type of needle in areas where you're really only going into soft tissue a couple of millimeters. And I'll explain why that is in a moment. You'll notice here that I gave you a different coloring convention than what's posted here in this picture. Ours for the extra short, the short, and the long needles is actually pink, blue, and yellow. So just remember that these colors on the screen are wrong. This was the only picture that I could get on short notice. But in our clinic, the ultra short is pink, the short is blue, and the long is yellow. Now I want to explain the concept of needle gauge a little further, so please listen closely because it can kind of be confusing. Needle gauge really refers to the diameter of a needle's lumen, and we use a number scale to indicate a needle's gauge. The number scale is somewhat counterintuitive in the sense that the smaller gauge numbers actually represent larger lumen diameters. For example, a 30 gauge needle has a smaller lumen diameter than a 25 gauge needle. Now, just in case this isn't confusing enough, needle gauge syntax dictates that when someone says, "Pass me a larger gauge needle," what they're referring to is a larger diameter needle and not a larger number. So when you refer to a larger gauge needle, you are referring to a needle with a larger diameter, although its numerical representation is relatively smaller. When you refer to a smaller gauge needle, you are referring to a needle with a smaller diameter, although the numerical representation for it is relatively larger. Now, I know that this is a bit confusing, but it's really going to be essential for you to be familiar for you to be familiar and also use this type of syntax when referring to a needle's gauge. There's going to be several questions throughout the semester on exams and quizzes that will require you to understand this concept. So my suggestion would be to listen to this section a couple of times, write it down, and read over it so you can get that relationship and syntax clear in your mind. Now you'll notice that these pictures kind of help. As the numbers get larger, the needle diameter gets smaller, and vice versa. Now, a long 27 gauge needle with a yellow cap that you will see down in the clinic are the largest gauge we have. The short 30 gauge needles with the blue cap are shorter and thinner than the yellow and consequently are smaller gauge. The ultra short, sometimes known as the extra short, pink capped needles are the shortest and thinnest we have and are of smaller gauge and length than the yellow or the blue. Now, one of the topics that I think is going to be really important when it relates to needle gauge is a topic known as needle deflection. Now, needle deflection is when a needle gets bent. Now, in context, what bends it? This deflection occurs when the needle is being unintentionally bent by the soft tissue that it's being inserted into. Now, this needle deflection does not refer to a needle being intentionally bent by the user. It only refers to the unintentional bending of a needle by the soft tissue it's being inserted into. Larger gauge needles undergo less deflection as they pass through soft tissue, and hopefully it makes sense why, because larger gauge needles have larger diameter lumens and therefore are a bit thicker and more resistant to bending. Now, the less deflection a needle goes through, the greater the accuracy of its tip. The hope is that the more accurate a needle's travel is to its intended target, the greater success you will have in providing anesthesia. Now, another thing that can cause deflection is the angle of the bevel. The greater the angle of the bevel, the greater the deflection. That's going to be important for you to know. Now, you'll remember when I was talking about the long yellow needles a moment ago that I said that you don't want to use those big, thick, long needles to penetrate areas of thin tissue. Now, these larger gauge needles are actually best suited for situations where you really have to traverse a long span of soft tissue, where needle deflection would be a concern, because these larger gauge needles are more resistant to deflection. That's why not only are these larger needles useless in thin tissues, but they also cause a great deal of trauma in thin tissue biotypes. Now, the concept of needle gauge can really be seen here in this electron microscope picture of different needle gauges. The larger gauge needles tend to have less deflection than the smaller gauge needles, and you can see that here, which means that their larger gauge needles are a little bit more accurate than smaller gauge needles. Now, needle deflection can be counteracted by slightly rotating the needle as you enter the tissue, something that the mechanics of and the muscles of your arm, forearm, hand, and fingers really kind of allow you to do automatically without even thinking about it most of the time. But when you do have to think about it, this technique has a name, and it's known as the birotational insertion technique, or BRIT. Now, essentially what rotating the needle does is that it neutralizes the perpendicular forces that are placed upon the needle by the soft tissues. Now uh, this can really deviate the tip of the needle from its intended target and make local anesthesia a little bit less accurate. Now, to counteract the deflection, um, what you do is you rotate back and forth as you advance the needle through the tissue. And this can really help in making sure that you are as accurate with your insertion as possible. So when you rotate the needle as you insert, it counteracts the lateral forces being placed on the needle by the soft tissue and keeps the needle on its intended path. Now remember, this technique is really only for situations where you're inserting the needle into a large bulk of soft tissue and is really kind of inconsequential in thinner tissue biotypes. Now, a few moments ago, we talked about self-aspirating needles, and you may have been wondering what aspiration is and why it's so important that it's performed. Aspiration is basically the act of sucking fluid back into the carpule to evaluate for the presence of blood. Now, how we do it is a little bit more involved. First, you insert the needle into the target tissue. Then you inject about 1/10 of a carp, which is probably about 8 to 10 drops of local anesthetic fluid into the tissue. Once you've done that, you then suck that fluid back into the carpule and evaluate it for the presence of blood. Now, can you guess why we do this? Now, the reason we do this is to make sure that we've not inserted the needle into a blood vessel. Now, you'll remember our lecture on the pharmacology of local anesthetics and vasoconstrictors, that these solutions are really vasoactive and can lead to some untoward clinical side effects. So it's essential that before we deliver a significant amount of local anesthetic that we verify that we're not inside a blood vessel. Aspiration allows you to do this. Although you should aspirate each and every time you enter thin or thick soft tissue, it's extremely useful when you're performing a regional block, such as an inferior alveolar or a posterior superior alveolar or a mental nerve block. More effective in those situations than if you performed a local infiltration, such as infiltrating local anesthesia into the marginal gingiva. The reason for this is really because, in general, when you give a nerve block, your needle not only approaches a nerve bundle, but also approaches major blood vessels as well, as opposed to a situation where you're doing local infiltration, where you're inserting into soft tissue that really only contains capillary beds. Now, it has been demonstrated that aspiration is easier and more reliable to perform using a larger gauge needle than a smaller one. The reason for that is that a smaller gauge needle has an increased likelihood of the harpoon at the end of the piston dislodging itself from the carpule's rubber plunger before even finishing aspiration. Now, although you'll be tested on this concept of aspiration, I'll be demonstrating how to do this in actuality when we get into the clinic. Now, as you've probably already figured out, aspirating your needle is a really important patient safety topic. Another very important patient safety topic is that of needle breaks. So what set of circumstances lead needles to break? Well, a couple of really important things that I want you to remember are the following. The weakest point on a needle assembly is at the hub. The reason for this is because the needle undergoes a great deal of cyclic fatigue at this point. You see, the hub serves as an anchor point for that part of the needle. Because the needle is fixed at that point, at the hub, it's not allowed to flex or move with the rest of the needle as the soft tissue deflects it. What ends up happening is the same thing as what happens when you take a metal hanger and bend it back and forth until it breaks. Essentially, this is a matter of material failure. That act of bending a metal back and forth repeatedly is known as cyclic fatigue. The next thing I want you to remember is that pre-bending the needle moves the needle a lot closer to material failure. And for the same reason, because a lot of people who do bend their needles bend them at the hub. Now, the next thing I want you to remember is that the smaller gauge needles break easier than larger gauge needles, and that makes sense. Smaller gauge needles are thinner, while larger gauge needles are thicker. The last thing is that the standard needles that we use at the school have not been designed to withstand large resistance forces, which basically means that you can't use those needles to penetrate bone, no matter how spongy or porous. Now, we'll revisit this topic of needle breaks later on in the semester, but for right now, I want you to remember the things that I just talked about. One more important thing that you'll need to remember, because it will be on the quiz and on the exam, and you will need to remember it for the rest of your life, is to never, and I mean never, insert the needle all the way to the hub. If you can't see that needle because it's so deep in the soft tissue, you've gone too far. And this picture right here can show you what happens when you insert a needle all the way to the hub. It breaks off, and because you have no visibility of where it is, you have to send that patient now for exploratory surgery. And because of all the muscle movements and movements created by musculature and by the vasculature as well, that needle can tend to transport into areas where it may be difficult to retrieve. So, remember, never insert the needle all the way into the hub. A few other items that I want you to remember are the following. And I hope that it's really obvious to you that you should never use the same needle on more than one patient. In fact, using the same needle for more than 3 to 4 penetrations, even on the same patient, should not be happening either. The reason for this is because the tip of the needle dulls each time it's inserted into soft tissue. The tip can even blunt, bend, or create barbs if it makes contact with bone, which can lead to a lot of pain for the patient. I mean, just imagine how much pain you would experience if someone pulled a barbed needle out of the soft tissue of your mouth. That would hurt for sure. Now, always make sure that you know exactly where the needle tip is while you're using it. And really, it sounds like a no-brainer, but we usually have a few students every year that try to wipe off the needle tip on a patient napkin to dry it off. Usually, it's that temptation of seeing that little drop of local anesthetic just hanging on to the tip of the needle, and you just want to softly caress the needle across a patient napkin. Never do this. And the reason is because once that needle tip touches a surface or a material or brushes up against a piece of equipment or suction tube, it's no longer sterile and should never be inserted into a patient's mouth. Doing so is not only a violation of OSHA regulations, but also unethical. So please be sure to maintain the integrity of the needle tip by not allowing it to touch anything except for the patient's oral soft tissues. Another thing to remember is that needles should be sheathed or capped whenever it's not being used. Obviously, an unsheathed needle is just waiting to injure someone. Once you are ready to recap a needle, you should do so by using the scoop technique. And I've posted a video teaching how to perform the scoop technique on this week's module videos. So once you are finished with today's video lecture, head over there and watch all the videos that I've posted, and they'll give you a little bit more understanding and context for what we've been talking about during this lecture. It's hard to do this online because we don't have the ability to be able to show you things in person, so those videos are really a great help for you to be able to contextualize the material that you're being presented with today. There will probably be a question about this information covered on this week's quiz as well. And finally, all needles should be properly disposed of in one of the designated red plastic sharps containers. Never ever throw away a needle or any other sharp, not even the glass carpule, in the normal trash. These need to go in these biohazard containers or sharps containers. Now, moving on from the topic of needles, we want to swing around and talk about the cartridge or the carpule. Now, the carpule encases the local anesthetic solution in a glass tube of sorts, with the needle end covered by an aluminum encased rubber diaphragm. And you can see that here. The rubber diaphragm is here. This black stuff is the rubber diaphragm, and it's encased inside of an aluminum cap just above the glass neck of the container. The harpoon end contains the silicone rubber plunger, and this is what the harpoon actually goes into, and this helps to plunge the fluid out or to aspirate fluid in. Now, I have published a video on how to assemble the whole needle, carpule, and syringe assembly, so please watch that video as well. That information will be covered, and this diagram and all the diagrams in this lecture will be covered on this week's quiz. You also have a couple of other things. The carpule also has the identification of the drug and also the formulation or concentration of epinephrine that is contained within this solution. It also has the drug identifying color code band, and you'll remember from a previous lecture that we talked about each one of the local anesthetics that are available in the clinic has their own designated color band. Now, just in case you were curious about what's inside an anesthetic solution, let's look at a carpule of lidocaine. Now, a carpule of lidocaine has the anesthetic drug lidocaine, which is diluted to 2%. And you'll remember the mathematics that we went through when we talked about how these are diluted. It also contains sodium chloride to help maintain the isotonic nature of the solution. There's also sterile water, which is a carrier of sorts. We also have epinephrine, which is at a concentration of either 1 to 50,000 or 1 to 100,000 in the situation of lidocaine. We also have sodium metabisulfite in situations where we're using epinephrine, and remember, sodium metabisulfite helps to protect epinephrine from oxidation or breakdown. Methylparaben used to be included in the single-dose vials, but is now only included in the multi-dose vials. Another topic that I want to very briefly talk about with you is the topic of topical anesthetic. It's a very topical topic. Now, you always want to use topical before inserting a needle into soft tissue. The way you do this is to make sure that you dry the target tissues with gauze. If there's too much moisture, then it doesn't work as well. Once you've dried the target area, place the topical anesthetic on the tissues for about a minute to a minute and a half. Now you can go up to about 2 to 3 minutes, but a minute to a minute and a half. It really is sufficient. Now you really don't need a whole lot of the topical anesthetic gel for it to work. About a pea-sized amount should be enough for one spot. Now, there are some topical anesthetics that do contain a small amount of alcohol, and alcohol has been known to actually contaminate or counteract, interfere with some of the workings of the local anesthetic that you'll inject thereafter. And we don't carry any of these in the clinic, but I do want you to know that there are some out there that do contain alcohol, which is an option in the future. Now, instead of telling you how to assemble your armamentarium, I really will direct you to the video that I posted on this week's module that will show you how to do that. But briefly, you want to retract the piston on the syringe and insert the cartridge or carpule into the breech. Once it's in, press the harpoon into the rubber plunger, and the last step is to screw the needle onto the end of the syringe. Now, important. I'm sure that you've all seen the famous dentist tap. We could almost make a viral video called the dentist shuffle, but instead call it the dentist tap. Now, I'm sure it looks really cool and everything, but the danger with doing this is that you can increase the pressure inside the glass tube, which can cause it to fracture, the glass to fracture. So my suggestion would be not to do it. Just gently press down, as you see here, to allow the harpoon to engage that rubber silicone plunger, and that should be sufficient pressure to get that embedded into the plunger. We really should create a viral video. That would be kind of fun. A quick note about handoffs, and when I say handoff, it's when you're handing off instruments either to or from your assistant. When you hand off or receive any instruments, you want to make sure that you make that exchange either above or below the patient's line of sight. Um, can any of you, looking at this picture, at these two pictures, guess why why I think that there's something wrong? What I think is wrong here is that this patient doesn't have safety glasses. Now, you always want to make sure that your patients have safety glasses on, because we work with sharp instruments, and we don't want to turn a dental appointment into an eye appointment. Basic injection technique involves injecting a few drops, like I said, 8 to 10 drops, or maybe even 1/10 of the carpule just after you insert the needle. Then you want to follow that up with aspiration. And if you have a positive aspirate, which means that you've got blood in the carpule, you stop, you withdraw the needle, you remove the contaminated carpule, and you replace it with a fresh carpule and make a new approach. Now, why do you want to get a new carpule? The reason for that is because when you reinsert, you want to be able to aspirate again, and you may not be able to tell whether you've got a positive aspiration the second time if you're using a carpule that already has blood inside of it. So always get a new carpule. Now, the unspoken part of your job when administering local anesthetic to your patient is to make sure that the patient is having a good experience. And a lot of this involves your powers of observation. What's the patient's facial expression? Are they wincing? Are they tensing their body? Are they furrowing their eyebrows or squinting? It's really important to not just sit there and observe this behavior, but to use this behavior to make course corrections to ensure that the patient has a better experience. That's all part of the practice of dentistry. And finally, a recap, pun intended, of safely recapping the needle is to use the scoop technique. And I have a video for you to watch on how to do this posted to this week's module on Canvas. Now, this concludes this lecture 4. And don't forget to discuss and quiz, and also make sure to watch the other videos that I've posted on this week's module on Canvas. Remember to send me any of your questions to me via email, and thanks for watching.